We're really pleased to have Dr. Padilla here with us. Many of us know him from prior periods of service in different venues. He was the CEO of Unity here in D.C., and I know he, medical director, advisor of CEO. Sorry about that.
Vince's job, but he didn't give it up. So.
Well, it's from this angle, it looked like you were the CEO. That's all we could see.
Yeah.
Anyway, I know you collaborated with many people in our department here in the Department of Health Policy and Management and in the School of Public Health more broadly and at GW. He actually has an appointment here at GW and teaches a class in the spring on community health.
Community Health Center Management.
Oh, okay.
It's
excellent.
the OPC track.
We have a series of speakers set up, and following Dr. Padilla, one a month, usually the first Thursday of the month, second Thursday of the month. And you have a list here of the program, so we hope you'll all put these on your schedules. And I'll let Ed Salzberg introduce Dr. Padilla.
Dr. Padilla was appointed Deputy Associate Administrator for Health Workforce and Director of the National Service Corps in February 2015, which makes you still relatively new in the Bureau of Health Workforce. As most of you know, HRSA and the Bureau of Health Workforce have a whole series of programs, and really the center of our federal policies related to the health workforce. And given Dr. Padilla's background in community health and family medicine, I think he's going to have an important impact on the policies and programs at HRSA and at the Bureau of Health Workforce. So again, welcome, Dr. Padilla, and look forward to your comments.
As I mentioned earlier before we got started with Polly, I'm hoping to introduce the Bureau of Health Workforce. It's a fairly new bureau that resulted of a merger between the Bureau of Health Professions and the Bureau of Clinician Recruitment and Service, which house the National Service Corps. So I'd like to highlight that merger, some of our programs, and in particular highlight some of the priorities that we see for health workforce. So I apologize if this is redundant for some of you who know HRSA very well, and some of you have been former colleagues of HRSA, so I apologize if it's redundant, but I was told there were some students here, and maybe they might not be familiar with HRSA. So HRSA is the principal agency that's responsible for improving the health and health equity through access to quality services, a skilled health workforce, and innovative programs. And it has as 5 goals: increasing access to quality health care and services, strengthening the health workforce, building healthy communities, improving health equity, and strengthening program operations internally. So to give you a flavor of its programming, through its bureaus and offices, it has currently an annual budget of approximately $10 billion, with the largest portion of that going to the Bureau of Primary Health Care, with a little over $5 billion. Then there's HIV/AIDS Bureau, the Maternal Child Health Bureau, and of course the new Bureau of Health Workforce. But we also obviously have a rural health component, healthcare systems and program management that make up the rest of the agency's budget. And again, to highlight that the Bureau of Health Workforce is a fairly new bureau. It was a merger back in 2014, in May of 2014, of those 2 other bureaus. And it really offered HRSA the opportunity to start addressing workforce from a longer pipeline, really. The 2 bureaus were administering programs that affected workforce at various stages. Particularly with the National Service Corps, it was distribution through the Bureau of Clinician Recruitment and Service, and the Bureau of Health Professions, academic support and training of health professions. So with that merger, it really allows the agency and the Bureau of Health Workforce to leverage its resources and investments throughout the continuum of so it really presents us a really valuable opportunity to look at our different programming and investment and really touch upon the lives of students and institutions who are training those students all the way through that continuum, and most importantly for us, where they're going to go do their clinical service or fulfill their health careers. So we see this as a very important opportunity for us. The Bureau of Health Workforce is going to support HRSA's mission and goals by improving the health of underserved and vulnerable populations, by strengthening the health workforce and connecting skilled professionals to communities in need. We're going to do this through our values of collaboration, accountability, and innovation. And I want to stress, and I'll be stressing through this presentation, that last part, connecting skilled professionals to communities in need. And you're going to see that and not only in this presentation, but hopefully you're already seeing that in our 2015 funding opportunities. You'll likely be seeing it in our 2016, this greater emphasis of placing skilled professionals in communities in need. So as we look at the work of the Bureau, the health workforce, we really see, as I mentioned, all of our investments in programming really increasing the supply of health workforce. And as I've repeatedly mentioned, our priorities of preparing a diverse workforce, improving workforce distribution, and ultimately transforming healthcare delivery. We think that we haven't stated this enough and really leveraged our programs and investments to highlight how we're, through our programming, able to transform healthcare delivery. So when we're looking at redesigning our programs and evaluating our programs, we're looking at the opportunities that we have to create and support academic and community partnerships, support and promote interprofessional practice and training, and utilizing our research and resources available to inform those decisions so that we're not simply making those policy decisions or programmatic decisions without the best available evidence and data that we may have in the area of health workforce. So this is a sort of a broad look at our approach. And as I mentioned, one of our priorities is preparing a diverse workforce, and we're happy to say that 47% of our trainees in our programs are minorities and or come from disadvantaged backgrounds. And I may be preaching to the choir, but we know that a greater diversity among health professionals is associated with improved health outcomes, greater patient satisfaction and engagement in their care. And we also know that the more students that we have from these backgrounds, the more likely they are to practice in those communities in need and be retained in those communities. So improving workforce distribution. Principally, we've been doing this through the National Service Corps for the last 40 years. That's been our primary vehicle, and we see that program as the primary vehicle for addressing the nation's gaps in distribution of health workforce, if you will. And we're proud to say that 86% of our National Health Service Corps clinicians continue to practice in underserved areas up to 2 years after they complete their service. And this has consistently been shown, whether it's independent assessments or internal assessments. It's been a consistent indicator of the program's ability to retain clinicians in those communities in need. But it's not, and just to highlight this, and I know we probably want to talk a little bit more about National Service Corps, but though we see this as the principal mechanism, we also see the other half of our portfolio of programs and investments being those academic programs, and really working with academic institutions to figure out ways to funnel graduates to these areas that necessarily won't participate in National Service Corps. Due to our funding constraints, we can't fund everyone to go into take advantage of our programs. But there are opportunities to still practice and fulfill your career in underserved communities beyond the National Service Corps. And again, lastly, transforming healthcare delivery. Again, preaching to the choir, healthcare is changing rapidly, and we need training environments, clinical environments to begin to change with it and even stay ahead of it. So in academic year 2013, 14, 12, BHW programs had an interprofessional focus, and within these programs, over 1,300 clinical training sites were engaged in interprofessional team-based care. We see the infusion, adoption, and expansion of interprofessional team-based care as important in transforming healthcare delivery going forward. So just give you a little snapshot look at BHW. As I mentioned before, $1 billion budget. We provided in 2014 over 8,500 organizations and individuals with more than 40 workforce programs. And collectively, our programs increase the nation's access to quality health care by developing, distributing, and retaining a competent health workforce. Again, 41 programs, really a wide portfolio of programs that encompass medicine, geriatrics, public health, dentistry, teaching health centers, area health education centers, interprofessional education, nursing, diversity programs, and mental behavioral health. So a wide array of programs that we support. Give you a look at some of the cumulative award amounts for some of these programs. But in addition to the programs, we also have housed within the BHW the Center for Health Workforce Analysis, which really is there to inform us in terms of program planning and development and policy making by examining a broad range of issues. We currently fund 6 workforce research centers thank you very much for your work, and congratulations for the award. And we recently awarded a 7th that will focus on mental behavioral health through a collaboration with SAMHSA. That award was given to the University of Michigan. I know that you applied. Very good application, and I didn't look at it, so don't throw anything at me. But I think that will give us an opportunity to look at mental health, behavioral health, integration, some of the questions that we have in the area of mental health. And the collaboration with SAMHSA is, for us, a very exciting opportunity. And we're scheduled for 2016 to redesign the National Sample Survey for registered nurses to include health reform issues. And as you know, George Zangaro is leading that effort. You are in favor, yes. Good. And again, another resource that we have that oftentimes people don't understand or are aware that is under the BHW is the National Practitioner Data Bank. And that is intended to improve the healthcare quality and protect the public by sharing information with authorized healthcare entities. Essentially, it's a reporting mechanism for any entity that staffs, privileges, providers of any adverse actions. The fee, there is a fee for that, either at an individual, institutional, or by a continuous query basis. Relatively low. I think it's under $4, and really required of many of our, for example, CHCs required to utilize it. We utilize it for the National Service Corps. Any applicant that we are going to award either a scholarship or a loan repayment goes, we check this data bank to make sure there haven't been any adverse actions. We feel that's an important part of delivering quality care to the nation. So when I was asked to give this, I was asked, well, talk about some of the opportunities and challenges. Well, they're mainly the priorities that we have. I mean, that's where we chose them as our priorities: diversity, distribution, supply, interprofessional education and practice. But there are others, and I'm sure that you have others that you see are priorities for us. And I'd like to maybe just end there and open up for questions, because I think there might be a host of them. I had some other slides on diversity. I'm happy to go into those in a little bit more depth, but I really would love to engage in a conversation and take some questions in terms of what you've heard or some input.
Great. Well, I'll throw out the first question, and we'll be sure to make sure that the folks on the phone have the opportunity to ask questions as well. So in thinking about the accountability of the academic institutions that you're supporting, in terms of both of producing clinicians that are going to provide services in the areas where we have shortages, as well as in those areas of medicine and nursing and allied health where we have shortages, like geriatrics. Mm-hmm. Do you have any evaluation metrics where you would actually track what the results of the schools are in terms of the kinds of students, graduates that they're producing? And if not, have you thought about that, and what kinds of measures might you use to hold academic institutions accountable for the graduates?
Right. So there are measures that we're including in those funding opportunities that would allow us to get metrics on the disciplines that they graduate. And we also have in some of our grants the opportunity to get information in terms of where they're going at a certain period out after their graduation. But I think that is sort of the holy grail in tracking of where students go. We would like to see that strengthen, and we're looking for input in terms of what are the metrics. There are some that are already there. For example, in our Teaching Health Center program, we have metrics that require the institution to report where they're going to practice, because we're interested in knowing if they're going into underserved areas. So they exist for some of our programs. They don't exist in others. But we would love to hear from you. What are some ideas in terms of the metrics that we should be using to track that and to hold academic institutions accountable for those measures?
There will be work occurring on that topic
mm-hmm.
from our
and we welcome that, because I think that that's important for us to track that. I will share that, if what we're interested in doing is graduating health professionals through the continuum as early as high school, because we have programs that fund those programs, those opportunities through HCOP, Center of Excellence, et cetera. If we're interested in tracking students through that continuum, how are we able to track that? We know that we're funding institutions that, let's say, give Luis a stipend or some support. Then he goes on to medical school and then gets an NHC award. it's limited our ability to track that individual through the whole process longitudinally. And ideally, that's where we would like to go. Yeah.
Can I follow up on that question?
Do you want to introduce yourself?
Yes,
Yeah.
so I'm Evelyn Lucas Perry. I'm a doctoral student in the School of Public Health. I'm also a director of public policy research at the American Dental Education Association. And so just kind of to piggyback off of that question, because I understand that for dental, or any kind of academic institutions, it's important to track students to see where they're going. But kind of more of a philosophical question, do you think that the school should be held accountable, like for not just the measures, but the actual practice behavior of their students? So, yeah, I'd kind of leave it right there.
Should always bring an ethics person with me, whether or not I should. I think that if we're using public dollars to train individuals, there is some level of accountability in terms of that academic institution, and not only who they're producing, but where they're going to provide that service. We certainly believe that at the federal level. That's what in part our mission is for HRSA and BHW. So I do think at some level academic institutions have that as their responsibility. And I think that that can be a positive for the institution, right? It's not a negative. It's not that. And I think that academic institutions in general would like to do this as, if you were to ask anybody, off the record, is this something you'd like to do? I think that most of them would say yes. I think it's more of how do we, from a policy perspective or programmatic perspective, do this and lessen that burden for academic institutions to do that. I think that's probably the rub there. I don't know if you agree or not.
No, I mean, I definitely agree with you. And obviously, I think with public investment, there is the accountability aspect. It's just sometimes I wonder if, the influence that you can have. Of course, it comes into who you're recruiting and who you're accepting into your pool. But also, the mission of the schools is to train and educate. And so that, being the primary focus and not necessarily where the students are going. So I can see kind of the tension going on.
Right. And I absolutely see the tension. And but I prefer not to, I guess my view is try to remain optimistic about this, that if we focus on that tension, we may lose track of that opportunity and overlay of mutual sort of priorities and understanding that we have. But I think it's important to have that dialogue, because I think that, and I've heard that what we're intending is not always in line with, and what we would like to see is not always in line with what the mission of various academic institutions. But I think that Fitz has made this case, social mission of medicine. I think he's made that quite strong.
The challenge is now to expand
the
other
challenge,
professions.
exactly. Well, I'm not quite sure we're done with medicine.
No.
I think the battle, not even battle, the persuasion is still going on there. But certainly, we're going to see that in nursing, LPN or licensed nurse practitioners, dentists. When you look at the composition and the demographic composition of those professions, dental assistants, pharmacists, right? So I think we still have a ways to go, and I think that it's good to have that dialogue, right? So I err towards the side of, yeah, we all have that responsibility.
Any questions from people on the phone?
Yes, I do have a comment.
Good, I'm glad I'm involved.
Go ahead.
Go ahead.
Hi, this is Irene Stevens from the Sullivan Alliance. I wanted to thank HRSA for their recent reports on diversity. One of them, not only a report referencing your diversity slides, the health workforce state profiles, but also the diversity of the health occupation. Recently, we had an opportunity to provide HRSA data to the Congressional Black Caucus Health Brain Trust report, and there was a section on workforce and I compiled the data to look at diversity and where we are. So I have an opportunity to thank someone for the contribution of the report and how hopefully that will translate into policy and inform, change maker in that area.
Thank you.
I wanted to ask, what are your thoughts about HRSA's role relative to changing, being a leader in setting examples and supporting models, but recognizing that others need to have an important role? So within the federal government, clearly CMS policies that support or encourage workforce change are important. In the private sector, it's what medical schools and nursing schools do. So how do you conceptualize the Bureau of Health Workforce's role vis-a-vis the many other players that we really need if we're going to achieve the social equity goals that you identified?
I think one of the primary areas is to continue to strengthen our data in that area. Particularly our sphere is in that area of underserved care, underserved data, health workforce, underserved students, underrepresented students, disadvantaged students. I think we have an area to fill that not necessarily CMS has that ability to do. So we see the National Center for Workforce Analysis as expanding that. It's certainly doing that through the Research Center. We're looking at ways to promote and make sure that really the public has access to what's already being produced. At the last meeting where you were there and Becky was there, both of us just came out of that meeting just wowed, the wealth of information that's out there. And I think an important role that we need to play is how do we disseminate that information so that we can inform policymakers and other agency leaders on these issues. So I think that's a central role that we need to play. In terms of the modeling, again, I think it, from a HHS perspective, our leadership is certainly interested in working with CMS. We're currently working with CMS on various national initiatives, and it's important to continue to have that dialogue. But for us, that central role is, I think, is critical, is that information that's getting out there. And again, making clear what our priorities are in terms of an agency and a bureau, and putting that in our FOAs. And really providing that funding for those models to take hold. And where there are areas of collaboration in those funding opportunities, we want to take advantage of them, like we're doing with SAMHSA.
So I'd like to
This
pursue.
is Jan. May I ask a question?
Sure.
Dr. Padilla, this is Jan Heinrich. My question is around the shortage designation process. HRSA has a key responsibility for updating those shortage areas. Some of us had the opportunity to work on revising the methodology for the shortage designation. Can you share with us where you are in the process of updating the methodologies that we're using?
Sure. So Jan, I've heard of you. I've never met you, so it's a pleasure virtually meeting you. So as you know, the Bureau currently is not changing the methodology. Now, we're currently under an interim final rule, or what we're operating under, since the committee that met in 2011 wasn't able to reach consensus. So we're currently operating under the same methodology we were before. What we're currently undertaking, and we've been undertaking since 2014 when the system went live in December, is the way that we're processing that data. And in particular, the new data elements and data input that we're currently using in that system, the National Provider Identification Number, the NPI number through CMS. And that's probably the most, would say, controversial, would that be a good statement, Ed? Element of that new system. So in terms of the methodology, we're not changing the methodology right now. Obviously, the agency is continuing to work on how it might move that IFR forward, and ultimately looking at the methodology and engaging, once again, depending on where that process finally lays out, what the appropriate methodology would be. That methodology is how old now?
Many years.
Many.
It could be 30 years.
Yes, 30 years. Is it reflective of need today, I would probably, not being an expert entirely on this, I would venture it's not. I doubt anything that's 30 years old is most applicable today. So I think it needs to be looked at, but we're not currently changing that methodology that's written in statute, as you know.
I think Jan, this is at Salzburg, Jan has raised a whole, there's many issues here that predate you.
Oh, yes.
Since they started trying to change that methodology in 2002, and Jan and I were responsible for the efforts in 2010 and 11. And the administration, it's a challenging case because if you read the statute, the administration really should be moving forward. Something to talk about offline rather than in this general setting. I'll just note that the work of the negotiated rulemaking committee, which was mandated by the ACA, was really strong work. Of course, I was responsible for it, so I'm biased, but it was really, I think, groundbreaking work, developing improved methodology for targeting so many of the programs of the Bureau of Health Workforce that hopefully your office and the new administration will use that as the foundation for anything going forward.
I think that there are a lot of elements to that, a great deal of elements to that negotiated rulemaking committee, the recommendations that are important to consider. I also think that from my own new perspective, it maybe didn't have all the data that it could have to arrive, and because that changes, correct? I don't think that obviously the NPI was not what it is right now. 3 years later, it was only slowly getting created by CMS. But I think further to Jan's comment, what we are doing is really taking a look at the input into that methodology and the system that was the best that HRSA could do at the time with the resources that it had available to it and how it processed those designations. We've done a tremendous amount of work in automating what was 20% automated is now 100% automated. There is no paper in the system anymore. That's an important step forward. And in fact, that system now will actually help in looking at what is the methodology that should be in place, because we now have a vehicle to assess some of the impact of the changes in that methodology. So that system that we have shouldn't be informing the methodology. The methodology informs the system that we have, and I think we have a vehicle there to help us out.
So for those who are students that may not know what everyone
Oh, yes. See, we're throwing out acronyms and this.
It's generally about how funding for federally qualified community health centers is allocated, and
and what we're realizing, if you don't mind, I'm sorry to interrupt you, but I think this is so. If you have insomnia, please look up HPSA and start reading it, and you will be cured of your insomnia, because it could make you very, very dizzy. It's a very complex methodology. It's a complex statute. It's complex regulation. But what we're learning now is it's more than the National Service Corps. If you have a geographic HPSA, you get a CMS bonus payment, which is 10%. That CMS puts out, probably about $500 million or more in bonus payments to primary care providers, well, any provider that's in that geographic HPSA. So there's a lot of money attached. There are a lot of states that have attached other state-level programs to that designation. So it is more than probably what it was intended to be done with it when it was created, and so it's a very complex process and methodology.
It's not just a technocratic question about how best to measure these things, since there will be
Absolutely.
winners and losers if there is a change in the methodology, and losers will not be happy.
Right.
So it's a delicate, technical issue.
Right. From a policy perspective, though, and I think it's important for students of policy to understand that when you're tying in funding to a particular methodology and designation, you want to invariably arrive at some rub. But Ed, I'm sorry, you were going to say something.
No, I'm sorry.
I think there was a question on the line as well.
I just wanted to, again, the negotiated rulemaking committee, which we met in person for 36 days, developed a comprehensive report. the data inputs, are improving, but we were really looking at the fundamental methodology, and there, unfortunately, there are fundamental flaws with the current methodology. So the way we count practitioners, we don't even count NPs and PAs.
Absolutely.
The way we measure need is clearly insufficient. And you're absolutely right. The way it's put is the group didn't reach consensus, but we had 20. We only had 2 objections out of 29. Unfortunately, we had made the error of defining consensus as unanimity. So there's really some important guidance there. And I think it's crucial because it is used in our count with about 25 federal programs.
Right.
And if we're really going to address underservice, then clearly using our federal dollars effectively is important.
No, and I think it speaks to not only that, but rational service areas, and really defining what is need and what level of need are we trying to address here. Those are important questions that I don't think the rulemaking committee addressed necessarily, and ones that we may have to revisit, because I think they're important global questions to ask before you venture into a methodology. But I think that the committee did amazing work, and we're going to continue to move that forward as best we can.
There was a question on the phone, and then I know Leighton was...
Yeah, I think there was a question on the phone.
Yeah, this is Darlene, and I'm going to glad for all that discussion and know that's happening, but I'm going to move to a little bit of practical. Does anyone know if the National Health Service Corps or anybody else tracks retention of scholars and loan repairs in FQHCs? Because sometimes people can recruit, but then keeping them beyond their repayment times. So we're looking at, is there any data tracking why do people move on?
Well, we conduct, thanks Darlene for that question. I think that's an important one because ultimately we want to try to keep qualified clinicians in those areas of high need and ideally in those organizations that they started their service in. We do have an annual survey, a participant survey, which we utilize to measure our short-term retention, and that's the slide that I presented there, 2 years out. We do that. And so what that statistic really looks at all the alumni in the program, whether they were loan repayers or scholars. So we have that data. Where it becomes difficult is getting the data and tracking them to see whether or not they're staying in those individual sites. So our measure really encompasses, and we have some data on the percentage that are staying at those sites, and that's roughly 50%. But the data that the measure that I quoted there was in any HIPSA area, any underserved area, 86%. The Lewin Group also looked at this, and I believe that FAAFP is going to come out with another report if they already didn't.
UNC, I believe.
I think UNC, right, as well. But what we found is fairly consistent results regardless of the study that's being done in terms of the retention, and we find that a significant portion of those, percentage of those participants stay in those areas, if not at their sites, at least in shortage designated areas.
7 years out, it's a little different story.
Yes, it starts to go out, but in this work environment, I mean, it's difficult to maintain and retain people, qualified people, 5 years out. But we're seeing a significant gain, even for those providers that are 10 years out. We see a fairly good retention.
That's all helpful. Anything that gets to the reasons why somebody will stay somewhere.
And so Darlene, to that, we in our survey we asked that not only of participants but of sites. What are the reasons why you chose to stay? What are the reasons why you chose to leave? And what we're seeing there is as sort of a gap in understanding between the reasons why a scholar or a loan repairer leave, and then the identified reasons why a site believes they stayed or left. So we're trying to close that exactly. And so why are we seeing that? Why are we not seeing that more aligned? And we're going to begin to address that. We're working on having a webinar for National Service Corps sites to present them the participant data. We've never done that before, to give them the insight and the information of what their NHC participants are saying.
Thank you.
Leighton?
Hi, this is
Cleve Erickson on the line. I have a question that's related to that. I was intrigued when the law changed so that you could do some of your participation for student loan repayment, that you could actually be eligible with part-time work. Have you seen any more interest in applications as a result of that, or is that related to retention at all?
Right. So it certainly is related to retention and recruitment. When I was on the Advisory Council of the National Service Corps, they did not have that option. Since its inception up to about 2010, the National Service Corps did not allow part-time service obligation contracts. We were pushing to have that change because it really wasn't keeping up with workforce needs. Many of our primary care providers are females who want and need to have family and need to take time off and aren't willing necessarily to come back full time. And other reasons, we had clinicians who were serving in leadership roles who were committed to working full time, 80% of their time clinical and no time or very little time spent towards leadership activities. And so we felt that this part-time option was really reflective of what the workforce was needing, and so that was changed. And it really wasn't a change in the law. I would just make one correction there. The law is what it says. It was a change in policy that the law allowed.
All right,
Right, thank you. And can I follow up with another question that are you involved at all in supporting telehealth to address any distribution challenges and access challenges?
Right. So that's a great question, and that's one of the first ones I posed in terms of the National Service Corps. We're outlining a roadmap of policy considerations for the National Service Corps, which ones are priority, and that rose to the top, or at least top three. When we, at this particular, I don't want to steal anybody's thunder in terms of your project, but what our site survey shows and our participant survey shows is the majority of those that are utilizing telehealth are mental health providers, and we see that. We see that in their requests to augment their contract, service obligation, et cetera. So we also recognize that our telehealth policy isn't exactly in line with the needs of that workforce right now, so we're looking at that. Our current telehealth policy only allows you to do no more than 8 hours of telehealth, 25% of your time. And it also requires you to do that telehealth from a HIPSA 14 to a HIPSA 14. And that can be challenging. So I think it's important for us to take a look at that policy and make sure that it's reflective, knowing that whatever policy we put in place isn't really going to be lockstep with what's happening in telehealth, because that's a rapidly evolving area of healthcare. But we are benefiting from our expertise in our rural health office that has a telehealth institute that is able to help us in how to craft that policy and how to assess its effectiveness. So we are supporting them.
Leighton.
Great, thank you.
So my question is perhaps a little unfair.
Oh, wait, as opposed to...
I'm going to ask you to sort of take off your hat for a moment in your federal role. No, given that up until recently you had not been a Fed, and so you weren't necessarily speaking for the Bureau of Health Profession or Health Workforce, but you've been doing work in this area for a very long time, in so many areas. And so, part of this that relates to where we are as a area that tries to work on health workforce issues, that as a department and a school in general that tries to focus on these issues. There are broader issues of opportunities for where there are ways to try to sort of deal with some of the gaps in equity of distribution of workforce, the sort of interprofessional areas, and there are things that we can do, whether through research or analysis, and at least exploring some of those areas, and not necessarily with federal funding either. And we have other resources too. So, part of my question is, if you had to think about areas where, and I guess part of my perspective is, the National Health Service Corps, many of the activities that the Bureau does are great, but they are sort of like a small, trying to fill gaps that are huge, and the resources that you have to do those are incredibly modest. And so the question is, what other sorts of activities or policies might the federal government be able to do to sort of help motivate some of these issues? And part of this is sort of along the lines of what Ed was asking, which is, sort of where are there broader opportunities to sort of motivate changes that affect training facilities, sort of healthcare providers in general, because, we need to move quickly in terms of, or at least from my perspective, it would be great to move quickly to sort of have more things in terms of team-based care across the board. Use, greater levels of mixes of different sorts of staff and work to sort of fill some of the distributional and maldistribution of healthcare providers. And we are facing a system that is resistant to change. The feds can do certain things explicitly through the resources and the grants you have, but they're a small part relative to a huge force. So, where are the other
levers, for example, around collaborating CMS on payment policy, those kinds of things you're thinking about?
That might be there. There might be
Yeah.
other areas.
Yeah.
I mean, certainly CMS payment policy is
Or with DOL and
is
those
one of
programs,
them.
or with,
Forever.
Department of Education.
And there may be areas that sort of go beyond, and in some manners, you perform my point to new types of legislation that would be necessary. Certainly in CMS, because I do a lot of work on those programs, some of the issues relating to some explicit policy activities, but certainly things like value-based payments, which is a big thing that CMS is pushing very hard, can have massive repercussions on safety net facilities, to the extent that a lot of the initial data suggest that in many cases, safety net facilities don't do very well with the metrics that are being used right now for performance measures. In part, I would argue that at least in part, it's because biases that are in the measures that were designed in ways that sort of don't accommodate what the needs of safety net facilities or the patients they serve are. But so anyway, so I don't want to prompt you for an answer there. But so the question is, trying to talk to us as researchers and analysts, from someone with your breadth of experience, what sorts of issues can we be trying to think of more broadly, as opposed to just the Bureau's programs and activities, which are important, but still limited.
No, I think those are all great points, and I would go back to what the ACA has been able to accomplish, and obviously the great strides that we've made in reducing the number of uninsured Americans in this country. We're at an all-time low, 40-year low of uninsured rates. So I think that's a great success. But where the ACA really didn't touch upon, and where the federal government really doesn't have much leverage, is in the area of scope of practice. And when we look at that issue, because we don't really have very many levers, if any at all, in terms of that, it's a challenging issue, because we know we have, and we could certainly argue about the data in terms of supply of nursing, NPs, PAs, but there are a lot of them out there that aren't being utilized to their full scope of practice in many, many states. And this does not allow them to leverage that workforce to meet their workforce objectives and certainly their health objectives. So I think that that's one particular area where academics and academic institutions can help us. What is the impact of that? What's the impact of, let's say, Pennsylvania expanding its scope of practice? What has happened there, so that other states might be able to look at that and say, well, maybe we ought to consider this. We know that obviously many states have not expanded Medicaid, right? That when we say that a lot of safety net organizations are hampered, this transition from volume to value, that is also further hampering their ability to do that. I know that Sarah Rosenbaum's looking at what exactly has been the change in revenue for community health centers that are in states that have expanded, because it's not clear whether or not they've actually seen revenue gains even with that expansion. Nevertheless, it's important. I mean, the majority of our safety net organizations survive off of Medicaid. So whether it's Medicaid payment reform or the expansion of Medicaid, and showing the impact, the real impact and gains of expanding or not expanding, I think is important. So I think that those are at least two areas. The other that I would say is interoperability of health information systems. Time and time again in my practice, I was stymied with communicating with GW, Howard, MedStar. You all use different systems. And I couldn't communicate with any of you unless I sent a fax or a phone. That can't continue to be the case. How are you going to achieve any of this in terms of health disparity gains if we're not even sharing information. And I think there continues to be institutional barriers to integrating there, financial barriers integrating, proprietary reasons why we're not integrating, but certainly the work of Dr. Spielberg and the CMS grant that Mary Center, Providence Hospital, Georgetown, or GW received in developing the CIN, and other projects like that to document the impact that that integration can have on a community, and reducing health disparities is important. I'll probably get fired for like half of that stuff I say, but, you know.
I've got a question. So I'm a second-year med student here at GW, and seems to me that a lot of what we're talking about in terms of loan repayment all comes from, is from how expensive medical school is and how expensive it's getting and continuing to get. Is there any consideration for trying to drive that down, or trying to look at, how efficient a medical education really is in terms of the cost? We had a financial aid meeting recently, and someone basically said, like, where is our tuition money going? And there's no transparency around that. So what I'm getting at here is, what role does tuition and the debt that people come out of school with play in the decisions they make to go into community health? Or
It's a huge role. Yeah. It's a huge role. As a medical director at a FQHC here, I saw that as a barrier to recruiting and retaining staff. I saw that at times I wasn't able to get the best person that I could because they had debt that they wanted to, you have a mortgage, right? Well, you want to pay that down, don't you? Same with loans. That's a burden on you, and it's actually a burden on the economy. So I think that's very important. When I write off on every award, in batches of award, I see, and it's not just medical students. The average dental student will come out with $350,000, $400,000 debt. So, and we have a critical shortage of dentists in the country, and this is driving many of those graduates to go into private practice, not into underserved areas, and that really undermines our objectives. So we see that as very important. Now, what can the National Service Corps do? We have the ability to adjust our awards. We can begin to look at whether or not we cap the amount that we're going to. Right now, when you're in loan repayment, you can just keep going until you're paid off, and then it doesn't matter whether you graduated from Harvard or some community college. You get the same amount, right? So there are opportunities there. They're challenging ones. But obviously the ideal would be for that educational cost to go down. We certainly are not in a position to do that or very much leverage that other than to say, you should take a look at that. But on the back end, there might be opportunities for us to adjust our policies to spread those dollars, because our dollars, our budget for the National Service Corps last year was, this year will be $310 million. It's a slight bump from last year, and then that's great. It's essentially level funding, which will allow us the opportunity to continue what we're doing for the next 2 years through the passage of MACRA. That's great, but that's it for us, right? We got to do what we got to do with 310. The president's budget's $810 million. When we talk about designation, we're able, for every $1 million, we're able to really bump up the number of awards we're able to give. And if we had a budget of let's even say $500 million, we would be able to fund down to HPSA probably as low as 7, 8, or 9.
Any other questions on the phone? Any thoughts on the feasibility of the Workforce Commission ever coming into being? You think it's dead?
It's in the law. As everything else, I think appropriations is what it ultimately comes down to, right?
Yeah.
Great. Any thoughts on collaborating with other agencies and the importance of bringing a health workforce perspective to their work and some of the challenges of that? I mean, not only CMS, but the other.
Yeah, I mean, we have a working relationship with the Department of Education. I don't know if this is sort of getting into the intricacies, but for a long time, we were hampered by our applicants' inability to have a streamlined, automated approach to their loan documentation. It took a long time for applicants of the National Service Corps to apply because you had to go get all these loans that were federal loans, and this federal agency wasn't talking to this federal agency. So we had an IT fix a couple years ago, and we basically migrated all the loan documents from the Department of Education onto our system, so that participants didn't have to do that, and we migrated that over. It reduced the amount of time that the application process took. We reduce our FTE load by 25 FTEs who were just processing those documents. So we saved a lot of money to the federal government and taxpayers by automating that process. So it's a much easier process. So I think we're going to continue to look at leveraging our opportunity to collaborate with other agencies. CMS, we're working closely with them in terms of the Shortage Designation Management System and the NPI, and really talking with them about where that NPI is going and what opportunities do we have to strengthen that system. How can we utilize it in other bureau-wide activities or maybe even agency activities. So SAMHSA, we continue to work with them. So any opportunity, we'll play with anybody is basically it. What I'm learning is it's not always easy to play with everybody. You know, we have certain different agendas, statutes, and so I'm getting a good education on the boundaries. But we're open.